Amy Wood channeled her skills into advocating for brain tumor survivors after her son's diagnosis, for a craniopharyngioma brain tumor in 2015. She is co-founder and executive director of the Raymond A. Wood Foundation, whose mission revolves around providing access to education, technology, and evolving treatments, and bridging the gap with the healthcare community to advocate for research that aligns with patients' priorities. In her capacity as a patient's advocate, Amy works to connect survivors and caregivers with educational opportunities that assist them in managing the complex medical condition resulting from these tumors and their treatments. So she's going to talk to us about the Raymond A. Wood Foundation.
Thank you, Anita. Good afternoon. Thank you so much to Kathy for inviting me to speak with you and to share with you about our work today. So first of all, just to explain a little bit about the Raymond A. Wood Foundation. We are a rare disease patient advocacy organization. We're parent and patient led. We were founded in 2017. It is named for my son Alex, who you see here was diagnosed at age 4 with a craniopharyngioma. And our mission is to empower survivors of hypothalamic-pituitary brain tumors for an improved quality of life by providing access to education, technology, and evolving treatments. The Raymond A. Wood Foundation is a proud grantee of the Chan Zuckerberg Initiative Rare as One Network Cycle 2, so we're one of 20 organizations that are within that network. So we work with hypothalamic-pituitary brain tumor patients. The majority of these patients are craniopharyngioma survivors. We also do work with germinoma survivors, hamartoma survivors, and I'm trying not to use the word survivors, sorry, patients. Someone said that this morning, so I edited my PowerPoint. But we're gonna focus mostly on craniopharyngioma, especially since that's the majority of our patient community. So just a little bit about craniopharyngioma. It's a rare tumor, approximately 620 new cases per year in the US. There's a bimodal distribution among children and adults, and the highest incidence is among our Black population in the US. This tumor is a solid and cystic tumor, some component of each, and they occur commonly in the suprasellar area of the brain, so right in the middle of the brain. So the question is, of all the brain tumors, is this the best one to get? Well, it's benign, it's treatable, it has a high survival rate, so what's our problem? Many families, including ours, were told at diagnosis that this was the best brain tumor to get. Yeah. So one of the quotes we refer to is from Harvey Cushing when he says, it's the most formidable of intracranial tumors. He was a neurosurgeon, so his approach to this, or understanding that where this tumor is in the brain, is tricky. A lot has changed over the years since he said this, but it still is a tricky tumor to treat because it's right in the middle of the brain, affecting so many parts of the brain that run our body's master control. So here are some of the issues. As in many brain tumors, the delays in diagnosis make this tumor even more difficult to treat, and there's no standard of care and treatment. So there are several approaches, a gross total resection that can eliminate the tumor but create more long-term effects. There's the combination of a partial resection and radiation, but that can create a more opportunity for recurrence. And then there's the radiation only, but that's rare that can be the only method of treatment. This tumor has the lowest quality of life of any pediatric brain tumor, and the ongoing medical conditions that result from the tumor or treatment of the tumor lack understanding, and many of them lack treatments. So I'm going to give you a snapshot of survivorship. This is a craniopharyngioma patient, my son Alex, who has hypothalamic impact. So before he was diagnosed, he was neurotypical, he was reaching his regular milestones, he was social, he had friends, he was verbal, he was active and healthy. The day that we discovered the tumor, he had to go into emergency surgery for a gross total resection of the tumor due to hydrocephalus. After the tumor, we were told, or during the surgery, we were told, it's a benign tumor, he'll be home in a couple days. So we were like, this is great, thank goodness, how lucky are we that he got it, not lucky that he got a brain tumor, but he got the best one. Within hours after he came out of the OR, we started hearing words like diabetes insipidus, hyper and hyponatremia, which is high or low blood sodium. He has loss of endocrine function. He began gaining weight within days with an insatiable hunger. He became aggressive. He started to demonstrate a lot of fatigue. Weeks and months after, he couldn't sleep. He was starting to have learning difficulties, sensory issues, noise, light, things that touched him. He developed orthopedic problems. He started to have eczema and psoriasis. Then we discovered that he had temperature dysregulation. He was diagnosed in the summer and treated in the summer, and in the winter he started slipping into hypothermia, which caused seizures and caused hospitalizations for weeks. He began to have social issues. He couldn't make friends. He had speech problems. We couldn't understand what he was saying. He had a complete loss of endocrine function, so he had adrenal insufficiency, which would result in adrenal crisis. Today, Alex is 12 years old. He's a wonderful boy with a big heart, but he faces hypothalamic obesity, which is an insatiable hunger, where he has continued weight gain, not controllable with diet or exercise. He eats non-food items or attempts to, and there's constant tantrums over food. We have to lock our refrigerators and our cabinets. He has ongoing challenges with managing diabetes insipidus. He drools, he has speech impairment. He was recently diagnosed with autism. He has an ADHD diagnosis and documented continued cognitive decline despite interventions. The good news is he doesn't have vision impairment. So we got lucky there. Most of our patients do have vision problems. We just did a survey analysis of the caregiver burden of craniopharyngioma patients. The paper is currently under review. But what we found is that the levels of caregiver burden for CP patients, as measured by the Zarit Burden interview, were found to be higher than those observed in caregivers with persons with dementia, Alzheimer's, and chronic pain. And 80% of caregivers could be at risk for depression. So caregiving is a challenge with patients with this tumor. So one of the things we started to see, or I started to see as I started participating in groups online post-diagnosis of Alex's tumor, is that all of us were struggling with some kind of guidelines, or how are we gonna manage this? What are we gonna do? And Tanya here says it best, there is no playbook for us. So we asked, how can we create the playbook? So what we focused on is seeking solutions for improving quality of life, and we do that through leveraging technology, becoming a voice in the research world, providing education and resources to our patients and families, and creating support and connection, which is vital. So could we leverage technology to help manage some of these conditions? So we're tackling a condition, we call it now a dipsic arginine vasopressin deficiency, the condition formerly known as diabetes insipidus. And this is a condition where the brain no longer makes vasopressin, which is your antidiuretic hormone, which controls your body's fluid balance. This occurs in 70 to 90% of CP patients, but a percentage of that have hypothalamic damage, which also makes them have adipsia, which is a lack of a thirst mechanism, making controlling your blood sodium levels really difficult because it's hydration and thirst related. And despite the fact that we can replace vasopressin, many suffer from too high or too low sodium, which can result in coma, it can result in seizure, coma, and can be fatal. But there's no FDA-approved means to test sodium at home. We cannot test blood sodium like we test glucose in diabetes patients. So patients are faced with multiple lab visits, sometimes daily, ER visits when labs are closed, and hospital admittances if the sodiums are out of range. So this is a very difficult condition to manage, and it's pretty much keeping your kid alive every day. So we figured out a way to leverage existing technology by finding that there's a handheld blood analyzer used in hospital ERs and veterinary clinics and urgent cares that can do a full basic metabolic panel on a finger stick and produce results in 3 minutes. Well, this was a game changer. Our family procured one, and it kept Alex out of daily lab visits where all his veins were blown out from too many needle pokes. We were able to get results in minutes so we could control his fluid intake and output and his medication, and he did not have any hospitalizations after for sodium reasons. So we decided to start the foundation to get these devices for other families. So that was our sole initial purpose. So after we did that, we discovered this isn't a sustainable solution because this is used off-label, it's a very expensive device. So we set out to develop a sodium meter akin to a glucometer. And that is currently completing phase 1 development with our partners at Children's Hospital of Philadelphia and Tumour Labs, and is being funded by the NIH and the Raymond A. Wood Foundation. So we are heading into phase 2, and the idea is that would be a home solution so that patients can test sodium rapidly and manage the condition. And this will not only work for our condition, but for other conditions that require sodium testing. Additionally, our patients have to measure their fluids ins and outs a lot of times post-surgery and report those back to the endocrinologist. So we also created an ins and outs app, which allows them to quickly log those numbers and allows clinicians to log in and see where the patients are. So that helps for their management of care. So that's one condition that we have to work with very closely. It's very tricky, and we're trying to find a way to make this easier for our families. So then we want to tackle research. How can we be a voice in research to support our patients? So this last year, we brought on a scientific advisor who assessed the research gaps among craniopharyngioma research, saw where the needs were, and how to build an infrastructure for us to support research. And that increases the chance for us to find meaningful treatment. So in research, we see a lot of duplicative research focused on the same thing that always says that line, more research needs to be done. So we're still looking for our answers in the areas of social issues, sleep impairment, which I haven't slept in 8 years, so I can vouch for how challenging that is with my son. So those are the things that we wanted to really assess and see what's out there so that we could develop a strategic research plan focused on the patient's priorities. And from that, we have moved to develop a patient registry that will establish the natural history of disease. So not only the tumor itself, but the subconditions like diabetes insipidus and hypothalamic obesity. We're working to gather evidence-based data on the viewpoints of patients and caregivers on the symptoms of importance so that we can then show our treatment priorities and also document the benefit and risk evaluation. And we want to develop an international, or are currently working on developing an international network of craniopharyngioma experts, including clinicians, researchers, surgeons, patients, caregivers, related organizations, and industry, with a hope that we can convene in person starting in 2025. Education and resources. So how can we become the best advocates for our loved ones? So we want to arm our survivors and caregivers with knowledge, because we know that when we walk into the doctors and the specialist office, that we get this small amount of time with them and we don't even know their knowledge base sometimes of all the things we're facing. So we host virtual conferences. This year in November will be our first in-person since 2019, and we co-host that with the Children's Hospital of Philadelphia. We also have monthly webinars that feature experts in all facets of survivorship and care management. We are building an online multi-language hub of curated medical information. We are also growing a library of videos on YouTube that are in English and Spanish. We are also distributing brochures on medications and conditions in both English and Spanish for endocrinologists to hand out to their patients. And we have a clinical trial finder on our website, and we also have physician finders in all the subspecialties that result from these tumors. And of course, creating connection. So how can we support each other in this journey? So we want to make sure that we empower our patients for support. We all know that the only ones that truly get it are the ones that are in it. So we offer monthly caregiver support groups. We also offer patient support groups led by survivors. We have buddy programs for newly diagnosed, and we also have mechanisms to share patient stories. One thing we do every year in May is the Art of Surviving, which is an online art exhibition. So we found that a lot of our patients use art as a therapy and also an activity, because in many cases our patients have temperature dysregulation issues, other issues that preclude them from being able to participate in sports or activities of their typical peers. So art is something they can do comfortably. So we wanted to give them a platform to express their selves, show their artwork, and so it's been 6 years in the running. This is our 6th year this past May. We had 80 entries, so it's growing. It's really a nice event. But our question is, what more can we do to make this better? So we're still on the mission to find answers, and I'm so lucky to be in a room with so many brilliant minds in this, because maybe someone out there has an answer, but we want to know, how can we reach underserved patient populations? How can we establish a standard of care or some sort of decision-making tree that when a family is presented multiple differing opinions on how to treat this tumor, how do they decide? And how can we support craniopharyngioma patients globally? So we want to work to kind of build a network. And that's really, we know through collaboration. And so we've been lucky to be able to collaborate with so many different entities across the issues that face our survivors. But of course, if anyone has any thoughts or ideas, I am always happy to talk. So please connect. Thank you.
Thank you very much. Thank you for sharing your story with us and sharing your family story, because as usual, like all kinds of diseases, not even to just brain tumors or to all cancers in general, it's a family story. It's not just a patient story. So do you have any questions for Amy?
Hi Amy, that was a brilliant presentation and really was very interesting to me because I am a craniopharyngioma fighter. I was diagnosed, I won't go into a big story or anything, but I was diagnosed at the age of 10. I'm not afraid to tell you my age, I'm 49. And so, and I've fought 6 of these reoccurring. They are benign, but unfortunately they like to grow back. And they grew back, I had 5 of them grow back within 1 year. So I had 5 craniotomies and 1 transpenoidal operation, which, because as Amy said, they are cystic and they're calcified. So if they're calcified, they have to do a craniopharyngioma, or they have to do a craniotomy. But if one time it came back and it just was, there was just fluid, so they were able to do an operation called a transpenoidal, which they go up through your nose and can drain it. But I'd love to get chatting to you later. Unfortunately, I have to leave in the morning. We're going back, so I won't get to see you tomorrow. So I'd love to connect with you maybe later at the meal. And I have just one question that I would like to ask. I know 5 people in Ireland with a craniopharyngioma, but they're all male, and I'm the only female. I haven't met anyone else that's female that has one. And I'm just wondering what the numbers are like in America, whether there are more male patients or female patients, or what's. It's just been unfortunate to meet another lady with one.
Yeah, well, I can connect you with other women, absolutely, but so the data shows that it's equal between male and female, but we do see a little bit more boys in our work, and I can send you the epidemiology report. It actually came out just about 2 years ago.
Yeah.
That really gets into kind of the age groups and the male, female, and all and that kind of thing. So I can send that to you. But I absolutely happy to connect you with some people too, some women, and I have a few that come to mind. So let's talk.
That's absolutely brilliant. Thank you very much.
Sure.
Hi Amy, thank you so much. That was a really inspiring journey and story that you've told us. I'm Catherine, I'm from the Brain Tumour Charity in the UK. One of the things that we do is provide support to people affected by brain tumours in general, So within that group, there are people with craniopharyngiomas, but we don't do as good a job as you do. So we would like to join your global support network, so I'll talk to you later about that.
Yeah.
But for everybody in the room who's probably focusing on, most of us are focusing on all brain tumours, not your particular one that you're focused on, how do you envisage us being able to join up? Can you say a bit more about that? And can I just add a part B to that? I was talking to a lady just last week who wants us to do a much better job, given her journey with her family being affected by craniopharyngioma. She wanted us to do a much better job with our diagnosis, signs and symptoms materials and our big campaign that we're doing. Can you tell us anything about how we should be picking up these tumours earlier to minimise the effects?
We were just talking about this, and I think the diagnostic odyssey, so in the rare disease community that we work with the CZI Rares One Network, the diagnostic journey is something that, it's so challenging because we see a lot of patients come to us and they say, we went to the doctor, our child was walking unsteady or suddenly gained a ton of weight, and the doctors just told us to have them stop eating as much, or maybe it's just a headache, or maybe it's the gluten that they're eating, and then the next thing you know, they're in the ER getting a MRI and discovering there's a mass in the middle of the brain. So I feel like, and maybe across brain tumors, this is an opportunity that we need to really get out there in front of GPs and pediatricians and say, look, if you see a patient that has suddenly gained weight or isn't growing or is throwing up out of nowhere, this needs to be further investigated. Please don't dismiss the parents or tell them they're crazy. We hear that all the time. And it's just unfortunate, and I don't know how to fix it other than to keep raising awareness. And then as far as supporting the craniopharyngioma patient, we hear this a lot, that we feel like we're outliers a little bit because we're not cancer. Our kids were not treated with chemo. We're not sure if we're cancer or not cancer. Typically because brain tumors might be looked at differently depending on where you are, and some do consider it an oncology issue. But it's important. I think the important distinction to realize is for many of us, either the tumor's long gone or the tumor's recurred and then stabilized, but now we're facing all these other things that are just not well understood or don't have treatments. Hypothalamic obesity does not currently have a treatment, and it is the most devastating because it impacts our socialization. We can't take our son out to parties. We have to watch everything he does. He steals food if we're in the grocery store. So it's a tricky thing, and that's why we have started a support group really focused, not to conflict with any other brain tumor organization support groups, right? But because it's just a little bit of a different journey. So I'm happy to talk with you further and share ideas, but
There's another question.
Sorry if I'm taking too much time now. It's more than 20 minutes. When you talked about this support group and you talked about underserved population, is there a possibility that in Pakistan, for example, we have craniopharyngioma patients, we can channel it through Komal's BTF pack, and there will be language barrier, there will be barrier of time, but I hope that works. It will help me a lot. Craniopharyngioma is one of those diseases. As a neurosurgeon, it always hurts me. Rajesh, you're a fighter, but then we are also fighting with you, and I'm a fighter too in this way. And it's a disease that embarrasses me always. There are very few instances where I have removed the tumor completely and the patient is perfectly fine. I come out as a victor. Most of the times, either I have caused a complication in an attempt to remove more, or I have left behind because I was very intimidated because of the previous experience. And I'm embarrassed to tell the parents. Usually it's the kids. I'm embarrassed to tell the parents that I have to leave this much part in because they expected me to remove all of it. So I constantly struggle with these cases, and when I try to tell them that this is how the disease is, it has an effect. They trust me, but I think a support group like what you have made will be a wonderful thing for them to work with. But my concern is these two barriers, language and time.
Yes.
If that can work out.
But hopefully we can, and that's why we want to expand globally and maybe develop some more support groups that would accommodate other languages and the time issue. We also have a very active Facebook group, so that might be an option too, where people from all over the world are part of, so that, but again, you're always welcome to direct them to us, and I understand your pains because
and it's not a rare, it's a bit, I mean, you know, at least in Pakistan, I see a lot of proliferate units. So Komal, I think we can work on that one, right? Tunneling, so thank you.
Thank you.
This is kind of question.
To say something that might give you some hope. This is a tumor that is included with non-malignant tumors when we do our statistics. But we did a webinar with the National Cancer Registrars Association in conjunction with a uro-oncologist to show them that this particular tumor, even though it's a benign tumor, it is a very, has such high morbidity that what they do is very important in collecting and making sure we count every one of those craniopharyngiomas. So I applaud all you're doing. It is a very devastating tumor.
Thank you.
Thank you very much.
Thank you. Thank you.